hospital bed. You're hurting badly. Maybe after surgery, maybe from cancer, maybe from a broken back, or pancreatitis, or sickle cell disease. And you press the call bell because the pain medication isn't working. The nurse walks in, looks at the computer, and says, "You're not due yet." And suddenly, something shifts. You stop feeling like a patient and start feeling like a problem. Welcome to Beyond the Stethoscope. I'm Arne Faklam, a nurse practitioner and fellow of hospital medicine. And this is where we explain what's really happening behind the scenes in healthcare in a way that actually makes sense. Today we're talking about one of the most emotionally charged, frustrating, and misunderstood parts of modern healthcare: pain control in the hospital. And this conversation matters because almost everybody listening either has experienced this personally or loves someone who has. So let's pull the curtain back. Before we jump in, if this is the kind of healthcare information you wish somebody had explained sooner, follow the podcast wherever you listen. And on YouTube, hit like and subscribe. It genuinely helps more people find the show. And if you want practical tools to help navigate a hospitalization, you can download the free Plain Speak Health Hospital Survival Toolkit and the medication guide at ps-health.com. That's ps-health.com. Let's start with something important. Pain is real, and pain is personal. One person's 8 out of 10 may look completely different from another person's. Some people are crying, some people are quiet, some people joke through pain, some people shut down completely. And hospitals know this. But here's the difficult reality. Pain management today exists in the shadow of the opioid epidemic. And that changed everything. Years ago, pain was often treated aggressively. Hospitals were criticized if pain wasn't controlled. Pain became known as the fifth vital sign. But over time, opioid addiction, overdose deaths, pill mills, and inappropriate prescribing forced medicine into a massive correction. And now, the pendulum sometimes swings the other direction, where patients with legitimate pain feel distrusted, undertreated, or dismissed. And honestly, sometimes they are. Not always intentionally, but it happens. Now let's separate a few different kinds of pain because hospitals think about them differently. First, acute pain. This is the easier category. Broken bones, kidney stones, major surgery, trauma, burns. There's a clear event, clear tissue injury, clear reason for severe pain. Most hospital teams are very comfortable treating acute pain. But even here it can become complicated fast, because pain medicine is not risk-free. Too much opioid medication can slow breathing, drop blood pressure, cause confusion, cause falls, cause aspiration, even death, especially in older adults, especially in patients with sleep apnea, especially when combined with alcohol, sleeping pills, or anxiety medications. So while patients sometimes think, "Why won't they just give me more medication?" the hospital team is simultaneously asking, "How do we control pain without accidentally harming this patient?" And that balancing act is harder than most people realize. Next, there is chronic pain. And when someone is hospitalized, yes, there can be acute and chronic pain. This is where things become much more difficult. Patients with chronic back pain, nerve pain, fibromyalgia, failed surgeries, severe arthritis, or chronic opioid use often arrive at the hospital already taking significant pain medication. And here's the reality many people don't understand. If someone takes opioids regularly, their body develops tolerance, meaning doses that might heavily sedate one patient may barely touch another patient's pain. So when a chronic pain patient comes into the hospital with something new, like pneumonia or a bowel obstruction or surgery, and also have chronic pain plus acute pain layered on top of it, and that can become incredibly difficult to manage. Because now the hospital team is trying to avoid undertreating pain while also avoiding oversedation. And sometimes those goals collide. Now let's address the uncomfortable part of this conversation. Patients with histories of substance abuse, because this is where emotions often explode between families and healthcare teams. Here's the truth. A past addiction history does not mean someone deserves to suffer. Period. Patients with prior opioid addiction, heroin use, or substance use disorder still experience real pain, still get kidney stones, still get cancer, still break hips, still need surgery. And good healthcare teams absolutely know that. But there's also another reality. Some patients are actively struggling with addiction during hospitalization. Some are withdrawing. Some are seeking medication compulsively. Some are mixing substances secretly. Some are at very high overdose risk. And hospitals know that too. So now clinicians are navigating compassion, safety, ethics, risk, and uncertainty all at the same time. And unfortunately, sometimes patients feel judged when what the staff is actually feeling is concern. But let's also be honest from the other side. Sometimes healthcare workers become cynical. Sometimes bias creeps in. Sometimes patients are unfairly labeled. And when that happens, patients can absolutely feel abandoned. So what can patients do? What actually helps? First, clear communication. Instead of saying, "They're doing nothing for my pain," be specific. What medication has helped you before? What makes it worse? What are you afraid of? What level of pain feels manageable? Because pain control does not always mean pain elimination, especially in hospitalized patients. Sometimes the realistic goal is making pain tolerable enough to breathe deeply, walk safely, sleep, or participate in therapy. Second, ask for the plan. Families often become less frustrated when they understand what medications are being used, how often they can safely be given, what the backup options are, what the limitations are, and who is making the decisions. Third, advocate respectfully but persistently. It is absolutely okay to say, "My loved one still appears to be suffering." That is fair. That matters. And good teams want to know that. But aggressive confrontations, threats, or assuming everybody is uncaring usually make communication worse, not better. What follows is an important reality, a difficult truth. Pain management in hospitals is not just about medicine anymore. It's about regulations, state monitoring systems, hospital policies, lawsuits, licensing boards, DEA scrutiny, patient safety metrics, addiction risk, respiratory risk, all of it. So when patients say, "Why is this so complicated now?" the answer is because modern pain management became one of the most scrutinized areas in all of medicine, and healthcare is still trying to find the right balance. But no matter how complicated pain management becomes, patients deserve compassion. They deserve communication. They deserve honesty. And they deserve to feel heard. Because when people are suffering, fear and isolation make pain even worse. And sometimes the most therapeutic thing a clinician can do is make a patient feel believed. Thanks for spending time with me on Beyond the Stethoscope. If this episode helped you understand something you've experienced personally, share it with somebody else. And don't forget to follow the podcast and subscribe on YouTube. And if you want the free Plain Speak Health Hospital Survival Toolkit, plus the medication guide, head over to ps-health.com. Until next time, I'm Arn Faklam, and this is Beyond the Stethoscope, where we explain what's really happening behind the scenes in healthcare in a way that actually makes sense.